Hi guys, welcome back to DMAD Lectures. Today the topic we will be discussing about is M blockers or muscarinic antagonists. So these two names are the same. Let's go ahead and understand about M blockers. So you should know that M here means muscarinic, right? So before talking about M blockers, maybe you should understand about the cholinereceptors or cholinergic receptors, because it will help you understand more about the M blockers. So let's go ahead and talk about cholinergic receptors first. Okay. So if we talk about cholinergic receptors, there are two main characteristics which you should know about cholinergic receptors, right? The first one is that cholinergic receptors use acetylcholine as their neurotransmitter, right? So cholinergic receptors use acetylcholine as their neurotransmitter, and they act on both central nervous system and the peripheral nervous system. So these are the main prominent characteristics of cholinergic receptors, right? So now cholinergic receptors can usually be divided into two main parts, right? The first part is known as N cholinergic receptors, and the second part is known as M cholinergic receptors. So why do we call it as N and M? Is because apart from acetylcholine, which is the neurotransmitter of cholinergic receptors, there are certain biological substances, right, which these receptors, these two types of receptors, might be sensitive to, right? So N cholinergic receptors, apart from acetylcholine, are sensitive to a substance known as nicotine, right? N cholinergic receptors are sensitive to a substance or biological substance known as nicotine, apart from acetylcholine, right? M cholinergic receptors, apart from acetylcholine, are sensitive to a substance known as muscarine, right? So since nicotine is sensitive, N cholinergic receptor is sensitive to nicotine, we call this N cholinergic receptor as nicotinic receptors, right? So M, similarly to N, we can talk as muscarinic receptors, right? So then again, cholinergic receptors are two types, N and M. N means nicotinic receptors, M means muscarinic receptors, right? So these two groups can further be subdivided, right? Before talking about that, let's talk about the localizations of these two parts. Now, N cholinergic receptors are usually found in skeletal muscles, right? In the regions of skeletal muscles, we can find N cholinergic receptors. Now, M cholinergic receptors are usually found in autonomic organs of the human body, right? So, I will not talk in detail about N cholinergic receptors, because M cholinergic receptors are the one relevant to the M blockers. So I'll be discussing about M cholinergic receptors in detail, but not N. About N cholinergic receptors, let's talk about in another video. Now, N cholinergic receptors, just for your information, has two types known as NM and NN, right? M here means muscles, N here means nerves, so it is about skeletal muscle innervation. Muscarinic receptors or M cholinergic receptors usually have 5 types, right? It starts from M1 to M5, right? M1, M2, M3, M4 and M5. 5 types of M cholinergic receptors are present. So this is the basic classification and basic understanding about cholinergic receptors. So let's go ahead and talk about the localization in specific on the M cholinergic receptors, right? So if we move on to M cholinergic receptors, I told you that there are 5 types, right? We have M1, M2, M3, M4, and we have M5. Out of these 5, M1 to M3 are the major receptors of M cholinergic receptors, right? M4 and M5 are minor. M1 to M3 are the main receptors. So if we talk about localizations, all these receptors are present in the central nervous system, right? All these receptors are present in the central nervous system, but there are other specific areas which these receptors might be present, right? For example, M1 cholinergic receptor we can find in exocrine glands. For example, we can find in salivary glands, we can find in gastric glands, for example, right? M1 can be found in salivary and gastric glands other than central nervous system, right? M2 especially is present in the heart and blood vessels, right? M2 is present in heart and blood vessels. M3 is usually present in smooth muscles, right? M3 is present in smooth muscles. M4 and M5, I mean, you don't need to remember these very thoroughly, but just for your information, M4 can be present in the lungs, M5 can be present in the eyes, right? So then again, M1, M2, M3, M4 and M5 are all present in the central nervous system, but apart from the central nervous system, these are the places which these receptors would be present in. So that is the basic understanding about cholinergic receptors, or the background information you need to know before we sort of dive into the today's topic, which is known as M blockers or muscarinic antagonists. So now let's start talking about M blockers, right? Now let's start talking about M blockers in detail. Now, first, if we move on to the classification of M blockers, usually it can be divided into two parts, right? The first part of M blockers, we can talk about non-selective, right? Non-selective M blockers, and the other type, or the other second section, is selective, right? So we have non-selective and selective M blockers. Non-selective, what does non-selective mean? Non-selective means it does not select, or it does not depend on a particular receptor. It can act from M1 to M5. Any receptor it can act, right? It doesn't choose a particular receptor, it acts on all of these receptors. Now selective M blockers, they can act on a particular receptor, either M1, either M2, either M3, something like that. So the two sections, non-selective and selective, are the main two criteria of M blockers. So if I give you some examples, right? If I give you some examples on non-selective M blockers, we can talk about, for example, atropine, right? We can talk about tropicamide, right? We can talk about tropicamide. We can talk about scopolamine hydrobromide, right, for an example. So these are, I mean, there are a lot of examples. So these are three main examples which we can discuss under non-selective M blockers. So if we move on to selective M blockers, we can have something like, for example, pirenzepine, right? We can talk about ipratropium bromide, we can talk about thiotropium bromide, right? So these are examples for selective, right? Selective M blockers. Selective means it acts on a particular receptor. So for example, pirenzepine, you can pronounce it any way you want. Pirenzepine usually works on M1 cholinergic receptors, right? This ipratropium and thiotropium might work on M3. So like that, these drugs are acting on particular cholinergic receptors. So this is the basic classification of M blockers, but in other literature, usually you might find some other types of classification as well. For example, in some literature, there could be M blockers can be divided into three types known as natural, semi-synthetic and semi-synthetic, or in some cases tertiary amines and quaternary amines, something like that. But this is the main or the most prominent classification of M blockers, right? So now, since we talked about the classification, let's move on to the mechanism of action of these drugs, right? Let's move on to the mechanism of action of these drugs. So basically the mechanism of action is very easy. If you look at the name, it means blockers, right? It blocks muscarinic receptors, right? So if I illustrate it like this, if you think of this as the presynaptic neuron, right? I talked earlier that cholinergic receptors use acetylcholine as their neurotransmitter, right? So we have presynaptic neuron, and then we have the postsynaptic neuron, which could be present in an autonomic organ. So as the organ, I'll choose the heart, right? So this is the heart. So usually we know that there is an M cholinergic receptor in the heart, which is an autonomic organ, right? So if you remember, I talked earlier, the particular type of M cholinergic receptor in heart is M2, right? So just to give you an understanding about how these drugs work, usually acetylcholine, when acetylcholine is released to the cleft, this is the synaptic cleft, right? This is the synaptic cleft. When acetylcholine is released to the synaptic cleft, it goes and binds to the M cholinergic receptor, which is present in the organ, right? So what these drugs do is that they block, right? They block this particular M cholinergic receptor, right? When they block this M cholinergic receptor, the acetylcholine cannot bind with the receptor, M cholinergic receptor. So the action of that particular receptor is not carried out, right? So what it definitely does is that it blocks the M cholinergic receptor and prevents it from interaction with acetylcholine, and the parasympathetic innervation of that particular organ is decreased, right? So that is the mechanism of action of M cholinergic blockers in general. But when we talk about atropine, if you remember, atropine is actually a non-selective M cholinergic blocker. I talked about it earlier. There is something called the biphase reaction or biphase response to atropine, right? So when we understand about the biphase action of the atropine, I'll draw something like this for better understanding. Now, like earlier, think of this as right. So think of this as the presynaptic neuron, and this is the heart. Oh, my heart has a hollow. Think of this as the heart, right? So it has M2 cholinergic receptor. So if you remember, I talked about earlier that all of these M cholinergic receptors are present in the central nervous system, right? So the type of receptor which you might find in the presynaptic neuron is M1. So M1 receptor is actually present in the presynaptic neuron, and M2 is present in the postsynaptic autonomic organ, which is the heart in this case, right? So, like I said earlier, acetylcholine is present in the presynaptic neuron. If we talk about the usual function of acetylcholine, right? If we talk about the usual function of acetylcholine usually goes and binds to M2 cholinergic receptor in the heart, and what it does is that it activates this M2 receptor, right? When acetylcholine is secreted to the cleft and when it binds to M2 cholinergic receptor, it activates this receptor and it lets it carry out its function, right? So simultaneously, acetylcholine, when it is binding with M2, it usually binds with M1 as well, right? When it binds with M1, it activates that receptor as well. Now the function of M1 receptor will be, it sort of decreases the amount of acetylcholine which is being secreted into the synaptic cleft. So usually in this case, when M2 receptor is stimulated, it causes bradycardia, right? When M2 receptor is stimulated or M2 receptor is activated, it causes bradycardia. But what happens here is that when this M1 receptor is also blocked by acetylcholine, too much acetylcholine doesn't get secreted, so it does not cause bradycardia. So there is an internal process which prevents the heart from going into bradycardia, right? If you don't know what bradycardia means the heart rate is decreasing. So, in this case, in atropine, what happens is that the function of atropine usually differs according to the concentration or the dosage of the drug, right? So again, I'll draw this. This is acetylcholine. We have M1 here, we have M2 here, right? So what happens is that when we draw atropine like this, if the dosage of atropine which is given to the patient is less, right, or the concentration of atropine is less in the drug, it goes and binds to M1 receptor only, right? Because you don't have enough atropine to bind to both receptors, it binds to M1 cholinergic receptor and blocks it, right? So if the concentration is low or the dosage is low in atropine, it goes and binds to M1 and blocks it. So acetylcholine cannot interact with M1, right? Acetylcholine cannot interact with M1 because it is already blocked by atropine, but it can interact with M2, right? Because it is not restricted here. It blocks, it goes and binds and activates M2 and stimulates M2 receptor to have bradycardia, right? So again, if the concentration of atropine is low, it only binds to M1 and blocks it, so that acetylcholine cannot bind to M1, but it binds to M2, stimulates it and causes bradycardia. Similarly, if the atropine concentration is high, right, or if the dosage of atropine is high, it goes and binds to both M1 and M2, right? It goes and binds to both M1 and M2 because there is too much concentration here. So it blocks both M1 and M2 receptors. So acetylcholine cannot bind either to M1 or M2, right? Acetylcholine cannot bind either to M1 or either to M2 because both of these receptors are blocked by atropine since it has higher concentrations. So if it is blocked, if M2 is not stimulated, the ultimate result here will be tachycardia, right? So if I simplify it here for you, when we have atropine, if the concentration is low in atropine, the heart rate usually decreases, or it causes bradycardia. If the concentration is high in atropine, it usually causes tachycardia or increased heart rate. So this is known as the biphase response to atropine, or the biphase reaction of atropine, right? This is a special effect which is present only in the drug atropine. So in the mechanism of action, you should know about the biphase reaction to atropine under M-cholinergic blockers. So I hope you understood about this. So now let's talk about the pharmacological effect and indications of M-cholinergic blockers, right? Pharmacological effects means the drug effect which has on the patient, and indications means why we should give the drug to the patient, or the reasons which these drugs should be given to the patient, right? So if we talk about the pharmacological effects, right? First one is that it increases intraocular pressure. IOP means intraocular pressure, which means the pressure in the eye, right? It can be increased. Second, it decreases the secretion of exocrine glands, right? It decreases the secretion of exocrine glands, for example, sweat glands, gastric glands, salivary glands, those kind of glands. It decreases the secretion of exocrine glands. And the third one will be it decreases the tonus of smooth muscles, right? It decreases the tonus of smooth muscles. Fourth one you can talk as it decreases the tonus of bronchus, right? It decreases the tonus of the bronchus, which causes bronchodilation, right? Bronchodilation. The final pharmacological effect, like I talked about earlier in the mechanism, it could be increasing of heart rate, right? So these are, there are several other reactions in M-cholinergic blockers as well, but pharmacological effects, if we talk about pharmacological effects, these are the main pharmacological effects you should know when it comes to M-cholinergic blockers. So in relevance to pharmacological effects, if we talk about the indications, right? If we talk about the indications of M-cholinergic blockers, it is easy if we talk in relevance with the pharmacological effect, right? For example, if it decreases the secretion of exocrine glands, right? If it decreases the secretion of exocrine glands, why should we give this drug? For example, if the patient is having ulcers, right? Gastric or duodenal ulcers. Because if there is hypersecretion in the stomach, it can cause ulceration. So we need to decrease the secretion of the gastric or duodenal glands. So for that, we can give M-colon blockers. So the indication would be ulcers or irritable bowel syndrome. In these cases, we can give M-colon blockers, right? So smooth muscles, for example, if the patient is having spasms, especially in the urinary tract, in the gastrointestinal tract, right? If the patient is having spasms, to relieve the spasm, we should decrease the tonus of the muscles. So for that, we can use M-colon blockers as well. Bronchos, for bronchodilation or decreasing the tonus of the bronchus, why should we give that? For example, asthma, right? Bronchial asthma. For bronchial asthma, we can give M-colon blockers. To increase heart rate, why should we give drugs which increase heart rate? For example, if the patient is having bradycardia, right, which means decreased heart rate, or if the patient is having AV blockage or blockade, right? If the patient is having AV block or bradycardia, we can give these drugs to increase the heart rate. So generally speaking, these are the pharmacological effects and indications of M-colon blockers, right? Now, let's move on to side effects and contraindications. Side effects are drugs which, side effects, right? Side effects means the effects which are not wanted from the particular drug. And contraindications, contraindications means why we shouldn't give this drug. So indication means why we should give this drug. Right. So if we talk about the side effects, right? If we talk about the side effects of M-colon blockers, there are certain prominent side effects we should know. First one is dry mouth, right? The patient might feel the mouth is quite dry because the salivation is decreased by this particular drug. So the patient might feel dry mouth. Also, the patient might feel like nausea, right? Or vomiting, right? The patient might feel these kind of things as well, right? And sometimes because of this drug, right? As a side effect, we can talk about bradycardia as well, right? Because if the dosage is quite low, especially in drugs like atropine, it can cause bradycardia, right? So bradycardia can come under side effect as well, right? So if we talk about some other side effects, we can talk about hypersensitivity reactions, right? Hypersensitivity reactions means the patient's body tries to react to that drug. For example, the patient might have skin rashes or itching or dermatitis, something like that. So all of these things, they come under side effects. So when we talk about contraindications, right? When we talk about contraindications, if you can remember, I told you one of the pharmacological effects of M-colon blockers will be increasing the intraocular pressure, right? So if the patient is having glaucoma, what does it mean, glaucoma? Glaucoma means increased ocular pressure, right? So if the pressure is already high, we don't need to increase the pressure anymore, right? So if the patient is having glaucoma, we cannot give M-colon blockers, right? Contraindications means, once again, contraindications means why we shouldn't give the drug. Right? So if the patient is having glaucoma, we should not give M-colon blockers because it will further increase the intraocular pressure, right? So if the patient is having tachycardia, right? Same here. If the heart rate is quite high, we should not elevate the heart rate anymore, right? So we cannot give M-colon blockers if the patient is having high heart rate or tachycardia. Or if the patient is having heart failure, chronic heart failure, right? If patient is having issues in the myocardium or the heart failure, we usually do not give M-colon blockers because it will be an extra effort on the heart. Same to here, if the patient is having chronic pulmonary diseases like chronic lung failure, right? If the patient is suffering from these kind of things, we usually do not give M-colon blockers. So these are some of the contraindications and some of the side effects which you should remember when it comes to M-colon blockers. So I think that suffices under the topic M-colon blockers. I hope you understood